mill about a little bit so that I can get to see everybody. I apologize in advance for my little raspy voice. I had a case of laryngitis last week and my voice hasn't quite come back yet. So if it gets a little crackly, you know why. So thank you so much. I appreciate the invitation to come and visit you. Your club is absolutely beautiful, and it's really nice to have a place where women can be together and be supportive for each other, because we really need each other. It takes a village, and the more the women stick together, the better it is, and I truly believe that. So why are we talking about cardiovascular disease today? Just to give you some of the facts, that heart disease is the #1 health threat that faces all women today. Heart attack and stroke are the #1 and #3 killers of women. And just to put it in perspective, a woman is much more likely, 10 times more likely to die of cardiovascular disease than she is of breast cancer. 10 times more likely. We're talking 35,000 deaths per year from breast cancer compared to 350,000 deaths for women from cardiovascular disease. So this really is a major, major public health problem for us in particular. And stroke, we even consider stroke, even though stroke is the #3 killer for women, more women at every age suffer stroke compared to men. Of all the strokes that happen, 60% of them occur in women. By the time women are age 50, 90% of women have at least one cardiovascular risk factor. And it kills more than the next 5 causes of death combined, cardiovascular disease. But the good news is that heart disease is 80% preventable. A lot of times we feel like our genes play a major, major role in what's going on, and it's a little bit of a genetic crapshoot, and we're doomed to whatever fate we have based on our genetics. But that's actually not the case with cardiovascular disease, because it is largely preventable. So where did this become a big health issue? When did we start paying attention to it? I'm just going to come to this point here, because I want you to just take notice. 1984, right there, this is the curves for male deaths, and the white is the female curve death. With advances in medicine, technology, stenting, good medications, the death rate for men really started to decline sharply in the late 80s and early 90s. And the American Heart Association started to notice a trend where the death rates for women during the same time frame were climbing, which didn't make any sense. And that's when everyone really started to take notice. And we've made some progress. The curve for women as of the last survey, this was published in 2012, is starting to shift downwards, but every year more women than men are still dying of heart disease, and this is something that we have to change. Interestingly enough, the American Heart Association, I've been a Go Red for Women advocate and a spokesperson for the American Heart Association since the campaign started back in 2002. And we do a lot of surveys with the American Heart Association just to get an idea of how much progress we've made, are we heading in the right direction. And interestingly, we've done surveys over the years looking at perception and awareness, because one of the big things about the Go Red for Women campaign is the message getting across. Are women aware that heart disease is their greatest health threat? And from 1997 to 2002, this was published in 2014, the awareness rate of women knowing that heart disease is a major health threat went up from 30 to 56%. So everybody's all happy and they patted themselves on the back and they say, good job, we're doing a great job. But when they talked to individual women, only 13% thought that heart disease was their greatest health risk. They still feared cancer, but didn't think heart disease was going to happen to them. It would happen to the person next door. So that was when we realized that we still have a lot of work to do. So what exactly are we talking about when we say heart disease? And that includes a family of diseases. The majority is coronary artery disease, which is blockage of the arteries, high blood pressure, congestive heart failure, and a little bit more of a minor portion, particularly in the United States, is rheumatic heart disease. We've largely eradicated that with the advent of antibiotics in widespread use here. And then congenital heart disease and diseases of the lungs. So when you look at the breakdown, that half of that pie is all coronary artery disease, blockage of the arteries. And if you include stroke and congestive heart failure, which is as a result of artery disease, it's nearly 75% of that pie. So it's a big portion of what we're talking about. We always think of heart disease as a disease as you age, which is true to a certain extent. But we see women of all ages, even in their 20s, have stroke, have heart attacks, have problems with weakness of their heart muscle, have heart rhythm abnormalities. So it's not just a disease of age.
But one thing that you do notice, by the time women are 65, they meet their male counterparts, and then they exceed their male counterparts in terms of the incidence of coronary artery disease and of all cardiovascular disease. And that trend goes all the way up on to 90 and beyond. So what actually is a heart attack? And when you think of a heart attack, you can think of that male, white male in his suit in a movie where he punches his chest, he breaks out in sweat, and collapses down to the ground. That's your classic Hollywood movie, not this Hollywood, but Hollywood movie heart attack, where they break out into a cold sweat, they get chest pain. However, symptoms of heart attack and heart disease in women can be very different. And you may have even heard already that women have more atypical symptoms, not so typical symptoms. One of the problems with those not so typical symptoms makes them a little bit easier to overlook. They may be very vague. It may be pain not in the chest at all. It could be pain in the upper back, in the neck, going down the arms. It may be unusual shortness of breath. Sometimes it could even present as more flu-like symptoms, where people would think, oh, I must have eaten something or gotten a bug, where they feel nauseated and sweaty, feeling of anxiety, loss of appetite. Very, very non-specific symptoms that can be often overlooked. But I don't want anyone to worry, because I'm sure all of us in this room have some of these symptoms right now, including myself. So the difference is that it has to be a change, something that's new for you. You used to be able to go up that flight of stairs coming into the club, and all of a sudden now you notice it's more of an effort. It makes you more short of breath, or it makes you more fatigued, or just your usual daily activities you're having trouble with. That's something that should ring a little bell in your head, that maybe something's going on and we should get it checked out. So why do we still see such a big gender gap? Why are there still so many differences between male cardiovascular disease and female cardiovascular disease? Well, it turns out that it's not just one factor. There's many different factors that play into it. Women in general may be less aggressively screened. I know so many women, particularly younger women, that the majority of their adult life they may only see a gynecologist, and they may not get some of the risk factor screening and the other screenings they would get. The awareness part of it, which is why programs like this are so important, getting educated that the symptoms might not be exactly the same. So we may link them to other conditions. I've had women who have heart attacks go to the gastroenterologist because they think it's a stomach problem. The other thing, too, which is a very, very difficult problem for women, is we sort of put ourselves very low on the list, and everybody else comes first. And the American Heart Association a couple of years ago did a really interesting phone survey where they called up a woman and they gave her a list of symptoms that her husband or the male in her life was having, and asked what she would do. And she said, oh, I'd call 911 and get her to the hospital right away. They did the same scenario, but told the woman that she was having some of these symptoms. What would you do? And she said, oh, I've got this meeting, and I've got soccer practice, and I've got 2 appointments the next day, and maybe I'll call the doctor in a couple of days. Same exact scenario. We put ourselves very low on the list, and everybody else moves higher up. And that can lead to big problems, because a lot of times women will delay seeking treatment because they think, oh, it'll go away, or it'll pass, or I have other things to do. Women still are less likely to receive the same therapies as men, and we're working very hard to fix that. The other thing, too, that from all of the data that we have and all the research on medicine and technology and stents and defibrillators, 78 to 80% of that was done in men. So we don't even have clinical trials that look at gender-specific therapies. If you ever get the opportunity to participate in a clinical trial, you see them sort of floating around sometimes. If you're a woman between the ages of, do it, because anything that we can do to get more data that just pertains to women, the better it can be for all of us. And it turns out that there are actually biological differences between women and men that make it harder for our heart disease to be treated. Can everybody see the screen? Is it okay? It's a video. If you look at the top artery, artery A, and compare it to artery B, you can see artery A in the middle has that big blockage. You see it? Right here? Right in the middle? That's more typical of a male artery. They're bigger and they have a tendency to get big blockages. And this is a female artery. You say, oh, that doesn't look so bad. But this artery actually has more disease in it because there's plaque here, 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 and here. Whereas this artery just has plaque right in the middle. The other artery, which happens to be larger, that artery is a lot easier to treat with a stent because you just have to open it in that one area. Whereas the female artery has blockages all throughout the artery, which makes it much more difficult to treat. And because of our size in general, our arteries are smaller. And sometimes the arteries may be too small to even put a stent in. And that creates a problem for us as well. So when we look at women who actually have been diagnosed with a heart attack or cardiovascular disease, even after that's happened, we're at higher risk. We're much more likely to die within a year of having a heart attack. After a heart attack, we're more likely to have sudden cardiac death, which is usually due to heart rhythm abnormalities. We're more likely to have another heart attack, have a stroke, or be disabled with heart failure. And women with congestive heart failure, that's rising at a very alarming rate. Some of that has to do with the fact that we're able to keep people alive after their heart attacks longer, but it's a major cause of disability in women, and it's something that we need to treat aggressively. So the question is, are we at risk? All of us are at risk. And we are really trying to change the focus of thinking of, oh, it's not me, it's her, or I'm not really at risk. It's really a spectrum of disease, and we all fall somewhere on that spectrum. Some are lower risk, some are higher risk, but we're all there. And I don't want people to worry or focus on the things that we have absolutely no control over. Unfortunately, we don't have any control over our age and subsequent birthdays. We don't have any control over our genetics, our ethnicity, and we don't have any control over what happened in the past. All we do have control over is the things that are in the future and the risk factors that we can modify. And we'll talk a little bit about those. But interestingly enough, all risk factors aren't created equal. Many of us have heard about blood pressure and cholesterol and how we need to be active and how we need to eat a healthy diet. Those seem to be similar for both men and women. But there are some risk factors that you don't hear a lot about in the news or in the media because they may not be as common, but they're really putting women at substantial risk. For example, smoking. You don't hear a lot about women smokers because in society in general, there are less women smokers than men. But a woman that smokes is 4 times less likely to have a heart attack compared to a male counterpart of the same age. So that particular risk factor is higher in women than compared to men. The same with women who have elevated triglycerides, a low HDL, which is the healthy cholesterol, because women have a tendency to have a higher HDL. Women diabetics are 5 times more likely than male diabetics to develop heart disease, stroke, heart attack. And we see higher prevalence of obesity, depression, and stress in women, and that also puts us at higher risk compared to males. So when we talk about cholesterol, everybody's pretty familiar with cholesterol. It gets a lot of play. Just so it's easy way to remember it, the LDL cholesterol is the lousy cholesterol. That's the bad one. That's the one that clogs up the arteries. The HDL is the happy, healthy cholesterol. That's the one that protects us and prevents the cholesterol from clogging up the arteries and climbing into the artery walls. About 15% of us have elevated cholesterol, so it's a very, very common problem. High blood pressure. High blood pressure has the nickname, which is a bad name, but it's called the silent killer. And the reason why it's called that is many, many, many women and men can go many years without knowing that they have high blood pressure because it doesn't really have a lot of symptoms. Yet it's a major cause for stroke, coronary artery disease, kidney failure. It's one of the very common reasons that people end up on dialysis. And I can't tell you how many times I'll see a patient for the first time who'll tell me that they had gone to a blood pressure screening. You know, they have those health fairs all the time. And my blood pressure was a little bit high, but they never followed up. They never did anything about it. And that can persist for years and years without having any symptoms. So it's really, really important if you ever know that your blood pressure is a little bit on the high side, that you follow up and get it checked again, because it's very treatable. When we talk about activity or inactivity, our modern lives have really affected the way how active we are. There's no doubt about it. We're on computers, we're in cars, we're sitting at lectures. We spend a lot of time being inactive compared to the old days, so to speak. 80 to 90% of women are not active enough, which only means 10% of the population is getting enough activity. And the definition of enough activity, according to the American College of Cardiology and the American Heart Association, is 30 minutes a day. Now that doesn't mean that you have to do 30 minutes every single day. If you do an hour, 3.5 days a week, it all adds up. but that's what's considered being active. With regards to heart health, that just means taking a nice walk for half an hour a day, which sometimes may be harder than others. But the activity part has to add up. So if you can only do a 10-minute walk, that's okay. So do a few walks a day. That actually is all we need for heart health. But as women, we also have to worry about other things. We have to worry about bone health and strength and keeping on muscle mass. And that usually requires a little bit of resistance training. And I don't necessarily mean pumping iron and lifting weights. It could be something as simple as using your own body resistance or using the stretchy bands, things like that, just to sort of keep the bones strong. All of these risk factors feed into each other. One of the things that happens, you're less active, so your cholesterol creeps up, your blood pressure creeps up, your weight creeps up. Then that increases your risk for diabetes. These are all cogs in a wheel. And once you sort of stop one risk factor, all the other risk factors improve. Obesity is becoming a big epidemic in the United States and in all parts of the world. Being overweight strains the heart, puts pressure on the arteries, can increase diabetes. And we're now seeing not only people being overweight, but seeing a lot of people progressing to the point where they become obese. And that's a major public health threat. I'm not going to go too much into this slide when I talk about the risk of diabetes, but as you know, it can affect the eyes, it can affect the circulation, amputation, kidneys. Diabetes is a terrible, terrible disease, and it really does affect every organ in the body. And when we talk about diabetes in this setting, I'm talking about type 2 diabetes, which used to be called adult onset diabetes, because it would happen when the body became resistant to insulin and glucose. Type 1 diabetes, which is the former term used to be juvenile diabetes, is when you're not born with enough insulin, so your body doesn't manufacture insulin. So that's a little bit of a different disease. The reason why they had to change the name of adult onset diabetes to type 2 diabetes is we're now seeing it in children in middle school, as young as age 10. So it really is becoming a problem that if we don't deal with that patient population, which is a different group of people, that those children will now be the next generation of heart attacks and strokes in the 30s and 40s, which is what we had seen a generation before. So that's actually something that is on everyone's mind, and there's a big public and health outreach to reach those young children to prevent them from developing diabetes. Smoking we talked about before. I really should have put this slide first, because as I mentioned, women smokers are at much higher risk of heart disease compared to their male counterparts. Smoking is the #1 preventable cause of death in the United States today. Not just related to heart disease, but every form of cancer. So if there's one risk factor that you have to work on, smoking should be #1 on the list. And if you still have anyone in your life that still smokes, it's really crucial to see if you can help them quit. Within 1 to 2 years after quitting smoking, within a couple of weeks, the coughs go away, the breathing is better, we start to see the lungs heal themselves. But with regards to cardiovascular risk, within 1 to 2 years, we see the risk go down tremendously. And after several years, it goes back down to what your age would be if you were a non-smoker. So it really is worthwhile, and it's never, never too late to quit. So I put this slide in here. It's really small. You won't be able to read it. I'll sort of give you the gist of it. I put this slide in here because women suffer more stress and suffer more anxiety and depression than men. Whether it's because we're the ones who are doing everything, might have something to do with it, or whether it's just because we internalize things more. Regardless, stress is a big problem in our lives, and it seems to just increase. The more we do, the more things there are on our list to do. And we're juggling families and work and volunteering. It just never, ever ends. Unfortunately, there's really no way to measure the effect of stress on your life or on your heart, but we know it's negative. Women who have had heart attacks have had worse outcomes with higher stress levels. So anything that you can do to lower your stress on any given day is worthwhile. Even if it's 10 minutes to listen to music or take a bath or just leave the house and walk around the block, anything that you can do to lower your stress, meditation, listening to tapes, it's really, really important. And don't feel guilty about taking that time. You need it. We're literally the glue that holds our families together. And if we're not healthy and we're not taking care of ourselves, if something happens to us, they're in bad shape anyway. So it really is important to prioritize your health and your sanity. Just a little bit about stroke. We talked about stroke before being a major cause of disability for women, and it's higher risk for women in every single age. The risk factors, though, for heart disease are very similar for stroke. So if you're working on lowering your cholesterol, getting more exercise, and keeping your blood pressure in check, not only are you reducing your risk of a heart attack, you're also reducing your risk of stroke. Over 500,000 women every year suffer stroke. And not only is it a major cause of disability, it's a major cause for women losing their independence and ending up in nursing homes. So it's really, really important that we modify this risk factor as much as we can. And one of the biggest take-home messages is that if you ever have any symptoms that you think could be related to a stroke, don't get in your car, don't go with the doctor or make an appointment for the next day. Call an ambulance and get to the hospital right away. You only have 3 hours to get the clot-busting medicines that prevent permanent damage of stroke. 3 hours is a really short period of time. So we like to say that time is brain. And there's a little acronym I want you to remember that tells you some of the symptoms of a stroke so that if it happens to you, you can think of it quickly and then dial 911. And it's called FAST. And you can remember that fastly. Facial drooping of any kind. If your face is off, if there's any asymmetry to your face, arm or leg weakness, where you go to grab something and your grasp is off, or you go to write something and you can't do it, or you go grab your coffee cup and it feels strange. Those kinds of weakness. Or if you feel like you're trying to walk and your leg is dragging a little bit behind you, that's something that you should pay attention to. Any kind of speech difficulty, and it can work in 2 ways. One can be difficulty getting words out, almost where you feel like you have marble mouth, where the words are getting stuck. The other is, and this one's sometimes a little bit harder, the other is this receptive speech. So someone is talking to you and you don't really understand what they're saying. The words don't make any sense. That's a warning sign. And then the last one is time. Time is brain. If you have any of those symptoms, it's always better to go to the hospital and get it checked out. If it turns out that it was nothing, at least you're in the right place at the right time if it happened to be a stroke. So as we were talking about before, the American Heart Association is trying to change the way we think about heart disease as being something you have or have not, but that it's a continuum of disease, and most people fit into the at-risk category, and that means that they have one or more risk factors. And as I mentioned, by the time we're 50, 90% of the population has at least one risk factor. And for all of them, quitting smoking, keeping blood pressure under control, keeping glucose under control, and increasing activity level is a given for everybody in the population. So there are some interesting guidelines that have come over the past few years that I just want to mention because some of them are controversial, and one day you may hear they're good, and one day you may hear they're bad, and it gets very, very confusing. So hormone replacement therapy, for many, many years, we saw the risk of heart disease and stroke go up after menopause. So for a long time, everybody thought, well, if you take hormone replacement, that should fix that problem, and that should be the end of it. Didn't happen. As a matter of fact, women who were on hormone replacement therapy had higher risks of breast cancer and had higher risk of blood clots. So the recommendation came away for hormone replacement therapy being recommended for cardiac protection, so to speak. But there are still women who are very symptomatic during the first few years of menopause or have weakness of their bones that hormone replacement therapy is still recommended. They're starting to do some more clinical trials looking at the timing of hormone replacement and whether or not would there be any benefit for a few years during perimenopause. We don't have that data yet. It'll be a few years before we have that. There was also, there's tons and tons and tons. Every time you turn on the television or if you watch any of the medical shows, if you watch Dr. Oz, every day there's a new vitamin that they talk about. This is going to be it. This is the one that's going to fix you. Vitamins are very, very difficult because they're not regulated by the Food and Drug Administration, so we really don't know what's in them. And the second thing is they've never really been studied in clinical trials, except for a few. There's a very big study called the Nurses' Health Study. Has anybody ever heard of that? The Nurses' Health Study is a very, very large study. It followed 65,000 women. This was part of the Framingham subset of data. And it followed them for many, many years. And it looked at some of the vitamin supplements, in particular vitamin A, vitamin E, vitamin C, the beta-carotenes, and folic acid. And it actually showed that it made absolutely no difference in their health or in preventing disease. what actually did make a difference were the people within that subset that got those kinds of vitamins and antioxidants, not from a pill, but in their diet. That sort of Mediterranean diet, the kind of things that we're eating today, is really the kind of foods that we want to be eating. And the theory behind that is that for some reason, the way that our body digests food and takes in nutrients is very different than the way it comes in a vitamin and the way that we absorb it. So that getting those vitamins and those minerals and those antioxidants from natural sources is really the best way to go. And there's also a study, too, looking at multivitamins. And it pretty much said that if you eat a healthy diet, you don't really need a multivitamin. The one thing that women definitely do need once they get to menopause is calcium and vitamin D for the bone health. And that's actually a big one. And there seems to be, and this is also somewhat controversial, there seems to be some benefit to the omega-3 fish oils. The omega-3 fish oils in the clinical trials did not show that it prevented disease, did not show that it prevented heart attacks or strokes. But what it does do is it has anti-inflammatory properties, and it naturally helps lower the triglycerides. And in the next decade, one of the things you're going to hear a tremendous amount about in all research is inflammation. Because we're starting to think that inflammation may be at the root of all disease. If an artery gets inflamed, it can't function properly, it doesn't have that protective coat, cholesterol climbs in and it becomes abnormal. A liver cell that is all inflamed and irritated, can't function properly, it mutates into a cancer cell. So we're going to hear a lot about anti-inflammation, but not the kind of anti-inflammation that you get in an Advil. The kind of anti-inflammation that you get from diet, from exercise, from lowering your stress, those kinds of anti-inflammatory properties that, as I said, may lower your risk of every disease. Another controversial thing is aspirin. One day it's good, one day it's bad, one day it's going to kill you, one day it's going to help you. Very, very, very controversial. It was just this study that came out, I think it was yesterday, talking about how it lowers colon cancer risk, if anybody came across that. So the current guidelines for women is if you're above the age of 65, there's absolute scientific benefit to taking a baby aspirin, coated baby aspirin a day. Between the ages of 50 and 65, it's a little bit controversial unless you're at higher risk. And higher risk would be if you have 2 or more risk factors. So if you have high blood pressure and cholesterol and you don't have any stomach problems, there's probably some benefit. If you're diabetic, for sure there's some benefit. Below the age of 50, there's really no benefit, and it actually increased the risk of, the biggest problem is really gastric ulcers because it irritates the stomach lining. So it really depends. If you're between the ages of 50 and 65, something you sort of want to think about a little bit. If you're above the age of 65 and you haven't had any bleeding problems, if you have bleeding problems, it's a different story. There is some benefit there, but for women, we really only need the baby aspirin. Higher doses didn't give any more protection in terms of heart attack and stroke, but did increase the risk for bleeding. So what do you do? How do we manage all of this? If you go for a regular physical exam, your general practitioner, or your medical doctor, all of these risk factors are assessed at every one of your annual physicals. But the important thing is one, to follow up like we talked about. Sometimes, as you know with medicine today, the visits can be really short and really brief, and it's hard to get everything in. I always recommend that you jot down some questions that you have, and you jot down the answers too, because sometimes you get out of the office and you forgot the things that were discussed. If you find that too overwhelming, bring one of your girlfriends from the club. It's really, really a tremendous way to get more out of your doctor's visit, because as you're having the interaction with the doctor, your friend can be writing all this down for you, and it just takes that extra pressure off of you of trying to have to remember everything. Know your family history, because that gives an idea of what your risk assessment would be. Know your risk. With regards to knowing your numbers, that was when we get back to the cholesterol and the blood pressure, because a lot of people know what these things are, but if I ask someone off the top of their head what their LDL is, they may not know. So it's important to know. And then the last thing is to follow up. If you go for your physical, and on the physical your doctor says, oh, you know, the sugar was a little borderline, blood pressure was a little borderline, nothing major, but that means you don't wait the next year or year and a half. Go back in 6 months, get it reassessed, get it checked out. So where are we with heart disease for the future? Because we still have a ways to go. We're still concerned that more women than men are dying every year. The American College of Cardiology, the American Heart Association, all of these national societies are really working on increasing education, which is always the first step, for doctors, for people in the community, for children, so that they're starting to live healthier lives. Advances in screening, early detection, aggressive follow-up. We really want to make a push for increased participation for women in the clinical trials. We're really starting also to look at more gender-specific therapies. As I mentioned to you, that some of those arteries for women are too small to put stents in. There's now a big push. We're making new stents, smaller stents, stents that will dissolve and become part of the artery wall. That's going to be the next generation in the next 10 years. And Cedars-Sinai is actually doing some cutting-edge research because some of the testing that we even have is less specific in women, things like stress tests, and some of the tests that we have are not as accurate in women as they are in men. So there's some of the research going on now using cardiac MRI to look at women's hearts and how they may differ from men. But that also is a way off in the future, and I don't really see that that will be a mainstream of therapy, only because of the cost. And as everything in medicine is going, cost containment is going to be a big push in the next decades. So I have a feeling that that won't be something that will be used mainstream, but for women who are high risk or get inconclusive tests, it may be a really good option for us. And there's a lot of upcoming research looking at stem cells, not embryonic stem cells, but your own stem cells, where you can actually take them and retarget for example, somebody who had a heart attack or has congestive heart failure, to see if we can get the body to regenerate itself somewhat. And that's some exciting research that if we ever get to that point, it really might actually revolutionize not just heart disease, but a lot of cares, including cancer care. So by 2010, the American Heart Association had the goal to reduce the mortality for women by 25%, which actually did happen. When we saw that curve, it did drop down 25%. But the health of the United States didn't really improve. We're still seeing higher rates of cholesterol and diabetes and so on. So now by 2020, the new goal is to improve health, get us healthier, get us feeling better, and get those risk factors under better control. But it's a little bit overwhelming because it seems like there's a lot to do. So this is sort of a simple way to manage all of your risk factors. And the first one is what we just did. Eat a diet that's low in saturated fat, salt, and cholesterol. If you stick to what I would call whole, real foods, not Whole Foods the store, whole foods, real whole foods, you don't have to worry about all those other things. Fruits and vegetables are naturally low in all of the above, salt, fat, and cholesterol. With the exception for fruits, some of the higher sugar fruits, just to keep in the back of your mind, bananas, grapes, and melons are the highest in sugar. The lowest in sugar and the best in terms of health benefit are berries, every kind of berry. Low in sugar, high in fiber, and lots of antioxidants. So you want to do more on the berry side and less on the banana side. And getting away from the packaged foods, the processed foods, the foods with a lot of preservatives, because that actually has been shown to have an inflammatory effect on the body. And one of the other things too is that the bread basket has become a staple. You can't walk into a restaurant without getting a bread basket. Unfortunately, as we age, we sort of lose the ability to metabolize carbohydrates in that way. Because if you were to eat a piece of bread or a bowl of pasta, it essentially dissolves into sugar, and our body never needs that much sugar at one time. So what does it do? It converts it into fat and puts it right here. Our body does not do the same thing with protein. So if you were to have, say, 400 calories of chicken breast versus a 400-calorie bowl of pasta, you would actually gain more weight even though they have the same calorie intake because they're metabolically different. Some of the things we talked about before, trying to keep your weight under control, being more active, keeping the blood pressure under control, keeping the glucose under control, and avoiding tobacco smoke at all costs, which has gotten easier now that it's not in restaurants. So there are resources. We're not alone out there. The American Heart Association has several websites. The Go Red for Women campaign is out there. Women who've actually participated on it online or through any of the programs have actually all made big changes in their lives. 90% of women who participate in some of these programs make positive changes. So that's actually really great. Changing their diet, lost weight, exercise. And actually, if you go on to the website, there's a lot of fun things you can do there. You can take your own private heart health checkup. You can set up a plan for yourself. There's lots and lots of options for you. And the website is goredforwomen.org, or you can even just type in American Heart Association. The other thing, too, is that at Hackensack University Medical Center, we've set up a Women's Cardiac Institute to deal with some of these issues. And we now I've collected a group of 11 female cardiologists that are just dedicated to the care of women and cardiovascular disease risk prevention, treatment, detection, and so on. So there's a lot more activity out there. 95% of cardiologists are men still, believe it or not. That's starting to change. But our medical center, we actually have a really good group, and we have a lot of women cardiologists, so I would take advantage of that too. And that's it. Thank you. Do a little Q&A.
Two questions. As you get older, your blood pressure rises. But it's always been held to the standard of 120 or 170. Have the numbers changed now if you're on the older side?
Well, there's two things about that. One is you're right, blood pressure does increase with age, and the reason why that happens is our arteries are they're rubber tubes. When we're young, they're very elastic. When you stretch out a rubber band, it relaxes and contracts. As we get old, just like the rest of our body, our arteries get stiff. So the pressure in the tube starts to go up. If we were to live indefinitely, everyone would develop high blood pressure at some point. Some people get it at 40, some people don't get it until they're 90. But it is an inevitable thing because of this stiffness of the arteries. Now, the question that you just posed about what's the new goal is very interesting because the study just came out also this week that you may have heard that we're not getting blood pressure low enough. And this came out looking at some of the trials, and there's lots of trials on high blood pressure that showed that every 10 points lower that you got, so if you got from 140 to 130, 130 to 120, each time you dropped 10 points, the risk of heart attack and stroke went down substantially. Substantially. So one of the things that came out of that study is, should our goal really be 110 over 70? But that is for people probably 65 and below, or maybe 75 and below, depending on how active they are. Because once you get the older patient population, 80, 90 and above, getting the blood pressure very low like that has some of its own risks. One is dizziness and lightheadedness. Another is that if the blood pressure is too low, the brain may not get as much blood flow as it needs because the arteries in the brains get very stiff. And the biggest concern that we have as physicians is there's a lot of falls. People hitting their head, breaking their hips. So in the older population, probably in the 8th and the 9th decade, I would say that we're still in that 130, 140 target. But for your younger people, for all of us, and for some of you who are on blood pressure medicines who are still very active, that goal of 110 to 120 might actually be a better goal for us.
Thank you. The second question is, if you take blood pressure medication and your blood pressure then is normal, is that considered still a risk factor?
It's a treated risk factor. So when you get that blood pressure, that was what I was saying, when you get that blood pressure down to that 120, 110 range, you are actually bringing your risk back down to somebody your age who really doesn't have that blood pressure. But you're on treatment. So a lot of times I'll have patients say, oh, look at my blood pressure is great, I don't need this pill. It's because you're on the pill. Yeah.
I'm a little confused about the aspirin. Does it help or not?
Over the age of 65, it absolutely helps.
Oh,
Between the age of 50 and 65, it depends on your risk. Below the age of 50, no.
What about men?
For men, it's a decade younger. So for men above the age of 50 to 55, definitely helps. And if you're high risk, meaning a lot of males in the family have artery disease, sometimes we'll even go as low as 45 for aspirin.
Why is your blood pressure reading highest in the morning?
It depends. Some people's are not. It really depends on the person. But one of the reasons, if you do have high blood pressure readings in the morning, there can be a couple of reasons. One is if you're on a once-a-day pill, the pill is pretty much worn off. So a lot of times we'll see the blood pressure start to come up, which it should. Because even though the pill is a 24-hour pill, it starts to wear off at 18 hours. So we do see that. The second thing is that early in the morning and when you first wake up is when your stress hormones are the highest. Things like cortisol, adrenaline, and so on. And that's one of the reasons why in men in particular, we see the most heart attacks early on a Monday morning as we're getting ready to go back to work because those stress hormones are very high in the morning. Those drive up blood pressure.
I was here, please.
Oh,
I'm so impressed with what you presented as the concerns that we should have and alerted us to.
mind there's an implication that medicine full of chemicals will be helping us, modifying it, eradicating it, or whatever. The concern I have is right now, and asking you this question, and that is the chemical ingredients to do with medicine are negative to us, but at the same time, these other positive things take place. You can kind of give me a perspective of the medicine taking and
Well, with
on
regards,
your body.
yeah, with regards to some of the medicines, we can never measure how the medicines are interacting in the body with each other, because that's not something they could ever study in a clinical trial. And anytime you can go without a medication, meaning do it the natural way, is always, always the best. But for many people, that's not an option. The blood pressure still may be difficult to control. There still may be plaque in the arteries, in which case you need the medicines. There are some medicines that we have lots and lots and lots of data on. I'm talking 20, 30, 40 years of data of benefit. I'll give you an example of a medicine that gets tons of talk in the media. One is the statin family of medications, right? Very controversial. It's terrible for you. It causes your brain to go bad. It's a chemical. It's not good for you. It can cause liver problems. That's true. So can red yeast rice, though. And a lot of people think, oh, I'll take that instead of taking the statin. Red yeast rice essentially is a statin, but without any regulation. The medicines that we have in the statin family now, they've absolutely been proven to reduce your risk of heart attack and reduce your risk of stroke substantially. And unlike a lot of medicines, we can actually detect side effects from it, liver problems, muscle problems, in a simple blood test. So even though it gets a lot of talk in the media, it actually is one of the safer ones because it's something that we have a little bit more control over. The blood pressure pills, there are some blood pressure pills that have a lot of side effects, but there are some newer blood pressure pills and pills like beta blockers, for example, that keep the blood pressure in control and keep the adrenaline levels down, that have been shown for decades to actually improve mortality and prevent deaths. So it sort of depends on the medicine. What I was talking a little bit before was the vitamin supplements and how we don't have a lot of data on it. But a lot of the medicines in heart disease in particular, we have good data to show their benefit. But I really am a big believer that less is more, and you really want to be on the minimum amount of medication that you need to protect your health, and then do as much as you can in a more natural way.
Thank you.
There's so many medications that cause, weight gain, and I'm just wondering about how do you decide that, balance between the harmful effects of added weight.
It's a difficult problem, and it doesn't happen the same for everyone. So you might take a medicine that will cause you to gain weight, and somebody else will take it, and they won't have that problem. Some of it's a little bit of trial and error, and it really depends on the severity of the problem. Meaning, if your heart's at risk or you're at risk of a major medical problem, then you have to take into account that you'll have to deal with a little added weight gain. But you don't necessarily have to completely deal with it. You have to counteract it, which means cutting down on the calories and boosting up the exercise. So it really is sort of a balancing act.
So just some follow-on question. Is it true they talk about different areas of fat in your body?
Yes. Well, the dangerous fat is the abdominal, this whole area fat, which is where, particularly after menopause, excess fat has a tendency to deposit. And this fat is actually the kind of fat that we call the bad fat. It has a tendency to store cholesterol. It stores cortisol, which is that stress hormone I talked about. Makes us more resistant to insulin, makes us more prone to diabetes. But the good part is that when you do start to lose weight, and the easiest way to do that is to start cutting out that processed food and the sugars we talked about and go back towards more whole foods, vegetables, lean sources of protein, that's where it comes off of first, and the risk goes down. So it works both ways. The other thing, too, is once we reach menopause, our calorie needs really start to go down, but our diets in our society have actually stayed, the portions have stayed actually quite large. If you ever see a little old lady who's just as thin as can be and really, really put together, they eat like birds. I mean, they eat very, very little because our calorie needs go down. So we sort of have to keep that in mind as we get older. Are you been waiting for me?
But I actually was going to ask you a question about statins, so I thank you for answering that. But I was going to also ask about, you mentioned about antioxidants. What about the
CoQ10? Yeah. For people who are on statins, CoQ10 is very, very beneficial because one of the reasons why some people get aches in their muscles is it depletes CoQ10 from the muscle. So in that situation, it doesn't prevent disease or it doesn't prevent heart attack or anything like that, but it does prevent the symptoms of the medicine by replenishing an enzyme that the medicine's depleting. So that's definitely a benefit, 100 milligrams a day.
Okay, and the other
For
question
onsets.
to add on to what they were saying about the blood pressure. So if I'm on a statin, my cholesterol is within the normal range. It's that same type of thing where it's, what did you call it, a treated risk
Yes.
factor or something?
Yes.
So that's,
So it brings you back, once you get your, whichever risk factor, doesn't matter which one it is, once you get that risk factor to your goal, you've now made yourself, even though you're treated, you've made yourself equivalent with your aged matched peer that doesn't have that risk factor. So that's how much it lowers your risk. So that's the importance of getting them to the goals that they need to be at.
Hi. First, I want to thank you so very much. Your presentation was so informative, and I'm sure we all enjoyed it so much and learned so much. But my question is, I'm the kind of person I don't like to take medicine unless I absolutely need to. Having said that, cholesterol-wise, what is the number you would recommend someone should definitely take their cholesterol number?
The number is a moving target, and the reason why I say that is it sort of depends on your risk. Now, if you're a diabetic, what you should have your cholesterol at is totally different than someone who has absolutely no risk factors and their cholesterol is a little bit high.
Not a diabetic.
Yeah, for general run-of-the-mill,
Right.
we consider therapy when the LDL, bad one, the lousy cholesterol, is above 160, and absolutely when it's above 190. Because regardless, we start to see plaque build up at that time. Now, there's a couple of caveats though about that. One is that if you're overweight and you haven't been exercising and you've been eating horribly, I'm not going to rush somebody to a statin medication when there's so much that we can do with diet and exercise and nutrition. But on the flip side of that, if you are active and you do eat healthy and you have a genetic history of everyone in your family having high cholesterol, that's a little bit of a different story because if you're genetically programmed to manufacture cholesterol, you can starve yourself and your cholesterol won't go down. So you sort of have to take, that's one of the cases where you have to really take genetics into account if you're already dealing with all the other stuff.
Okay, now, like say Lipitor versus Crestor. I mean, I've heard different.
Of the cholesterol pills that are out there, Lipitor and Crestor have been the ones that have been shown to reduce heart attack and stroke the most of the ones that are out there. Zocor, which was one, or simvastatin, which was one of the medications that's been around for a very, very long time. The problem with it is it's not as concentrated, so you need higher doses to have the same effect. And at higher doses, we start to see more risk, meaning for side effects. And at higher doses, in particular with simvastatin, it interacts with a lot of other medications that get metabolized through the liver. Now, that used to be a big problem because for a long time, simvastatin was the only generic decent cholesterol pill we had on the market. But this past year, Lipitor has gone generic. So now that's available. Lipitor and Crestor are very similar, but Crestor is the most concentrated, so you can use it at the lowest dose to have the same effect.
Thank you.
It's not a question, it's a sharing more like a sharing. My mom is 77 years old, and a few years back, she started, having a problem with high blood pressure. She was prescribed 2 different medications, and each of them had really bad side effects that she struggled with. So she felt bad without the pill, she felt worse with the pill, and so on. And I stumbled upon the simple exercising, even energy medicine, and I shared it with her, I just showed her on Skype what to do and breathe in, breathe out, and how to do it. She started doing it twice a day, and she found out by measuring her blood pressure that she had her blood pressure stabilized just by spending a few minutes in the morning and a few minutes in the afternoon. So I was impressed. I don't have any statistics to prove that this is actually, would work for everyone, but
that goes back to what we were talking about, the effect of stress.
Also with stress and
on the body.
the natural tools of reducing cortisol. And there's been studies recently published of how to reduce cortisol within 12 to 15 minutes by 24% within the study group. It's a tremendously high number.
It's tremendous, and
it is huge.
The
within
effect
15 minutes, no drugs.
The effect of stress on the body, even stress that you don't even perceive.
What I wanted to say that I'm so inspired to meet a medical professional who is for prevention and for natural methods of helping people rather than just writing prescriptions. So great.
When is it suitable for someone to see a cardiologist if there's been no event?
If you are having any symptoms that aren't explained, that's a good time. Or if you're having trouble with your medical practitioner, whether it be a nurse practitioner, an internist, a family practitioner, controlling any of those risk factors, then that would be a good time to take it to the next step. If you are developing mild symptoms, mild shortness of breath, things like that, it is worthwhile to get it checked out. If nothing else, have a baseline from which you can compare to in the future.
Getting back to the lethal multivitamins, which I do take a lot of, because you talk about getting it from your diet. You can eat the best diet in the world. The heat, light, storage, and the soil condition all affect the nutrient value of your food. And you know, as well as any of us, that the vegetables grown in the soil that our grandparents ate, it's not the same as the soil now. So I mean, for myself, yeah, I do take multivitamins.
Yeah, a lot of people feel better. They feel like they're at least getting complete nutrition. With regards to the food and the way that food is processed, you're absolutely right. I mean, there's so many things that come into it, the way they're grown, the pesticides, you name it. Anytime, there's been a big push in this area towards cleaner food. So anytime you can get near a farmer's market, there are actually a lot of co-ops, if you've been familiar with that come from organic farms where you can have fresh vegetables and fruits delivered to your house as part of a cooperative if you want to get access to fresher foods. And then in our area, Whole Foods and Trader Joe's, all of their fruits and vegetables are claimed to be organic, and that doesn't necessarily take away some of it because there are still pesticides, there are still some other things there. But do as much as you can do is probably the best advice I could give.
I have a silly question. I know the answer.
I think did your question get answered?
Did you ask a question?
Okay.
I don't. I'm so sorry. I'm trying to accommodate them, but this is a really foolish question. I can almost answer it myself, but maybe I don't have the right answer. So you gave an example that when you have an illness or some symptoms, you take a certain medication that you'll get it exactly right. Let's say it's going to be that medication will put your blood pressure or whatever at the right spot. Okay, so now you're on the right spot, and you're on the right spot, and the right spot, and the spot. Does it ever take over naturally? Is there any portion of that will be something that maybe because you are now
where you won't need it anymore?
No, not ever again. Not ever, totally. I'm saying then you suddenly are eating right, you're doing like exercise, and so then all of that, we don't know what percentage is what affecting that, and if we think of it's medicine. I'm just curious.
No, well, there are very, very, very often patients that are overweight and their diet has not been good and they haven't been exercising and they want to go on a program and it takes them maybe 6 months or longer to get to where they want to be. But then as everything improves, you start pulling away the medications. You don't want to keep somebody on medications that they don't really need.
How do you know?
We monitor it.
What?
You monitor it. Because
the
blood pressure will start to go, the blood pressure will start to go lower.
How do you know it's not the medication that's doing the job?
Well, once you start going below the goal, you start cutting them in half, and you sort of see where their sweet spot is, so to speak.
Thank you.
Yeah, there's cards up there, there's brochures from the hospital. I think there might even be some on here. Thank you so much. Thank you. It was nice to stay. Thank you so much,
Thank you. I was asking Therese to tell you that I believe this belongs to you.
Oh, thank you so much. She didn't. Thank you.
You're welcome.
I appreciate that.
Yeah.
she tells that your presentation team want to go up there and you can go together and say for everyone, how to I guess that's not you already. Okay,